Hello, colleagues. How are you? I suppose that you read a lot because the exams are coming. Yes, yes. Alive, please. Colleagues, if you want, you can download this lecture. And if you have another plans about the learning, I'm agree that after today or tomorrow, after tomorrow, I will answer to your questions. If you want to, if you want to speak about irregular heart rhythm now, tell me. I don't know what you prefer, because you can download this lecture. Okay. Now we will start. This is common arrhythmias in children. We talk about arrhythmias in children. This is a common pediatric problem. The etiologies are different. Clinical manifestation is from normal benign variants to malignant arrhythmias. Very different clinical signs. What you know about the types of irregular heart rhythm? The first is asymptomatic child, and the second group is symptomatic child. In the first group, there are sinus arrhythmia, ventricular premature beats, atrial premature beats. In second group is atrial arrhythmia, supraventricular arrhythmia, and ventricular arrhythmia. The first disorder is sinus arrhythmia. This is normal physiological variant. The increased heart rate during inspiration and decreased heart rate during expirations. This is typical for sinus arrhythmia. What about the cause? There are changes in parasympathetic input to the heart, which is mediated by the vagus nerve. During expiration, enhanced vagal tone lowers the heart rate, and during inspiration, vagal withdrawal increases the heart rate. Sinus arrhythmia is abolished during active exercise because vagal tone is decreased and the sympathetic tone is increased, resulting in a repeat heart rate throughout the respiratory cycle. You can see in this electrocardiogram. This is the sinus arrhythmia. This is very typical for this is state is very typical in childhood, because in childhood the rhythm normal rhythm is up to 220 beat per minute. For a while, please. Ventricular premature beats. Premature depolarization of the ventricle lead to early systolic contraction on the ventricle. You can see this picture. VPB are usually followed by a pause and occur without regularity. This is very typical. You have to know that in normal children, in health children, there are normal up to 5 or 6 ventricular contraction, abnormal beats, premature. Also, these ventricular premature beats also may on occasion occur in an irregular pattern every other beat. The name is bigeminy, or every third beat, this is trigeminy. Generally benign, and this is benign and produce few or no symptoms. I told that that is normal. Ventricular VPBs commonly occur in infancy, decline and incidence in early childhood, and become increasingly common again in adolescence and adulthood. The next situation is atrial premature beats. Early depolarization of atrial myocardium lead to propagation of electrical impulses through the atrium and to the ventricle via the atrioventricular node. And the result is early systolic ventricular contraction, and atrial premature beats occur most commonly in isolation in this picture. These situations are benign, and this these states are benign and are unlikely to be associated with sustained tachyarrhythmias. What about atrial arrhythmias? Most commonly seen in children with congenital heart disease who have undergone cardiac surgery. This is very typical. Atrial ectopic tachycardia and focal atrial tachycardia. You can see the picture. Very, very typical is this electrocardiogram. The second is the typical is multifocal or coatic atrial tachycardia. The next is atrial flutter. It's possible to be atrial fibrillation. This is severe disorder. Supraventricular tachycardia. An electrical impulse cycles repetitively through a circuit from the atria to the ventricles and back again, and result is repeat regular ventricular contractions. Common clinical manifestations are palpitations, chest pain, fatigue, and lightheadedness. In infants are typical pallor, fussiness, irritability, poor feeding, and or cyanosis. Most children, this is about the clinical presentation, most children tolerate short episodes of tachycardia well. Prolonged episodes can precipitate heart failure. Also, I want to talk that certain forms of supraventricular tachycardia may be associated with VPV, Wolff-Parkinson-White syndrome, typical in childhood. Ventricular tachycardia is uncommon in children without underlying heart disease. Causes of ventricular tachycardia are inherited channelopathies. For example, long QT syndrome, catechol-aminergic polymorphic ventricular tachycardia. This is the second disorder. It's possible to be ventricular tachycardia to be idiopathic. For example, right ventricular outflow tract tachycardia. This has benign course. Cardiomyopathy, for example, this is the cause of this is the cause for ventricular tachycardia, and in this group are hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy. The next cause is myocarditis. The next is coronary heart disease, very rarely in childhood, and congenital heart disease. What about sinus node dysfunction? Unappropriate sinus bradycardia or chronotropic incompetence, failure to appropriate elevated the heart rate in response to physiologic stress. Very typical. This is common complication in patients with complex congenital heart disease and with inflammatory disease. For example, myocarditis, Kawasaki disease, rheumatic heart disease. Initial evaluation typical is typical is the first to be correct history. History is important. In history, there are important elements. The first is palpitations. They are manifestations of a single beat, non-sustained tachycardias or sustained tachycardia. Very important is to be this accurate description. The second element is a history of syncope. What is a syncope? Syncope defined as sudden, brief loss of consequences associated with loss of postural tone from which recovery is spontaneous. There is an increased risk for an underlying serious cardiac disease and for a life-threatening cardiac arrhythmia. The next step in history is you have to ask about the chest pain. In childhood, very rare, but you have to ask the patients. Family history is important. Familial sudden unexpected death. If in a family history there is a familial sudden unexpected infect, you have to think about VPV syndrome or catecholaminergic polymorphic ventricular tachycardia. What about the physical examination? Complete description of the irregular heart rhythm because several conditions have characteristic findings. The first, respiratory cycle. Any consistent change of the heart rate in relation to the respiratory cycle should be noted. In a cooperative child, the patient take large inspiration and hold it, I show you, hold it prior to exhaling while the rhythm is being assessed. The next is isolated ectopy, an irregular early heartbeat followed by a pause. This suggestive of VPV or atrial premature beats. When you see bradycardia, this suggests of sinus node dysfunction or second degree atrioventricular block. In every case, we have to perform electrocardiogram. What you can see, the first sinus arrhythmia, VPB and APBs may be found during rhythm strip depending upon their frequency. Second degree of a block is identified by ACG. In the picture, this is a second degree of a block. I'll show you a short PR interval and a delta wave with a wide QRS confirms pre-excitation, and result is most often in the form of VPV syndrome. In the last picture, you can see VPV syndrome. The wave inversion in the right precordial leads V1, V2, V3. This is right precordial leads, and epsilon waves. This means that there is a arrhythmogenic right ventricular cardiomyopathy. A prolonged QT interval show congenital long QT syndrome. You see in the picture. Brugada syndrome. This is pseudo-right bundle branch block and ST segment elevation in leads V1 to V2. Cordial V1 to V2. Hypertrophic cardiomyopathy. We can see in electrocardiogram prominent voltages with localized or diffuse repolarization abnormalities. Cardio referral. referral to a pediatric cardiologist. When? Because we are pediatrician, but when we refer to a pediatric cardiologist, the first is when initial evaluation does not result in a diagnosis. The second, the patient is symptomatic. The 13th, when and or the ECG demonstrates a clinically significant abnormality. For example, VPV syndrome, and there are prolonged QTQ interval, second or third degree AV block, sinus pauses, or other signs of sinus node dysfunction, VPV or paroxysms of supraventricular or ventricular tachycardia. Another testing, you know about Holter monitor. This monitor provides a continuous rhythm recording from adhesive electrodes for a minimum of 24 to 48 hours. Event monitor, very important because transtelephonic devices, it's possible via transtelephonic devices, but it can be used for 30 to 60 days. And this device show, for example, activation by the patient, continuous monitor this result, and smartphone applications. Exercise testing. The goal is to observe the effect of enhanced sympathetic drive on the rhythm status in a child with an ACG or Holter monitor abnormality. The next test is echocardiogram, and the last is invasive electrophysiological study. This means cardiac catheterization procedure during which the heart is stimulated and responses to these stimulations, and they are assessed. And this lead to definitive etiology and assessment of the severity of the arrhythmia. The management in children of this disorder. Most of these arrhythmias require no intervention. Treatment of supraventricular tachycardia depends on presentation and symptoms. The first is vagal maneuvers, application of cold, for example, ice back to the face, antiarrhythmic therapy, intravenous adenosine, synchronized cardioversion is important in patients with cardiovascular compromise at the time of presentation. The dose is 1 to 2 joules per kilo. The next step is a variety of antiarrhythmic agents that can be used to treat ventricular dysrhythmias that require intervention. The second issue of this lecture is heart failure in children. Structural or functional cardiac disorders that impair the ability of the ventricles to fill with and or eject blood. This is the signs are the typical for heart failure are cardiac output is insufficient to meet metabolic demands of the body. The second is cascade of compensatory responses. And third is restore normal perfusion to the body's organ and tissues. These are 3 points very important in heart failure. The causes of pediatric heart failure can be divided into the following pathophysiologic categories. The first is ventricular dysfunction. The second is volume overload with preserved ventricular contractility. And third category is pressure overload with preserved contractility. These categories may overlap in some patients. This categorization helps us to understand underlying physiology and clinical manifestation of the different causes of pediatric heart failure and guides the approach to management. Ventricular dysfunction leads to impaired ejection of blood from the ventricle. Ventricular dysfunction implies systolic dysfunction. There is reduced ventricular contractility and diastolic dysfunction. There is impaired ventricular filling and high ventricular filling pressures. Ventricular dysfunctions, systolic or diastolic, can occur in children with congenital heart disease and in those with structurally normal hearts. For example, cardiomyopathy, myocarditis, and complete heart block. Volume underload with preserved ventricular contractility. In most cases, most commonly, it is due to congenital heart disease with significant left to right shunting of blood from the systemic to pulmonary circulation. This is very important to understand. Cardiac causes are ventricular septal defect, patient ductus arteriosus, atrial septal defects, aortopulmonary window, atrioventricular septal defect, aortic regurgitation, mitral regurgitation, pulmonary regurgitation. The second group are non-cardiac causes. They are arteriovenous malformation, for example, extracardiac shunting, fluid overload, for example, oliguric renal failure. The next group, the next pathophysiological process is pressure overload with preserved ventricular contractility. It is most commonly due to congenital heart disease with ventricular outflow obstruction. And there are the disorder, for example, aortic stenosis, coarctation of the aorta, pulmonary stenosis. Sorry for a while, please. Sorry again, colleagues. Symptoms of heart failure vary with the age of the patients as follows. In infancy, typical is tachypnea and diaphoresis during feeds, easy fatigability, irritability, decreased volume of feeds, poor weight gain, failure to thrive. In the next group, young children, the clinical symptoms are gastrointestinal symptoms, abdominal pain, nausea, vomiting, and poor appetite, failure to thrive, easy fatigability, and a recurrent or chronic cough with wheezing. Sorry, but Dr. Vuchkova. We can continue. In older children, clinical manifestations are exercise intolerance, anorexia, abdominal pain, wheezing, dyspnea, edema, palpitations, chest pain, or syncope. Physical findings vary depending on the cardiac output, degree of volume overload, and pulmonary congestion, and or systemic venous congestions. Signs are the first, tachycardia. It is a response to decreased cardiac output in patients with depressed myocardial contractility. The second is poor perfusion. This is a result of diminished cardiac output that lead to cool and mottled extremities, decreased capillary refill, decreased peripheral pulses, and lowered systemic blood pressure. What about galvapritam in children with diminished cardiac output or when there is a volume overload? For pulmonary findings, the first is tachypnea. This is the most common findings of pulmonary congestion. Normal respiratory rate varies with age. Other signs of respiratory distress, these are retractions, use of accessory respiratory muscles, and in infants, grunting with nasal flaring. We can auscultate wheezing and rales. Out from the result from systemic congestion are hepatomegaly, the most common, ascites, and splenomegaly. The second group is jugular venous distension, not generally observed in infants and young children. You know why? Because the neck is very small, and the peripheral edema. Other findings are high blood pressure, but it is limited to upper extremities and or feeble pulses in lower extremities. When we see this phenomenon, we have to think about aortic coarctation. Systolic murmur in patients with outflow obstruction in hypertrophic cardiomyopathy or aortic stenosis, congenital heart defects with left to right shunting. For example, ventricular septal defects or mitral regurgitation. Diagnosis is based on a combination of clinical, radiologic, echocardiographic, and laboratory findings. Non-invasive imaging studies and laboratory tests are chest radiography, electrocardiogram, and echocardiography, and laboratory tests are BMP, this is brain natriuretic peptide, troponin, complete blood count, and serum chemistries. Unstable patient pumped initiation of treatment to restore adequate perfusion. When the patients are unstable, they have severe cardiorespiratory compromise, shock, or implementing cardiac arrest. Chest radiography is very helpful to assess cardiomegaly and pulmonary congestion, and they helps us to monitor the effectiveness of heart failure treatment. Cardio may be seen in left to right shunting defects, dilated cardiomyopathy, myocarditis, arrhythmogenic right ventricular cardiomyopathy, restrictive cardiomyopathy, and pericardial effusion. Electrocardiogram help us when the child has sinus tachycardia. This is the most common ECG finding, but are non-specific. ST segment and T-wave abnormalities. When there are, we think about cardiomyopathy and myocarditis. Increased QRS voltage show that the child has ventricular hypertrophy, and we think about hypertrophic or dilated cardiomyopathy. When QRS voltage is decreased, we can think about myocardial edema or pericardial effusion, myocarditis, deep Q wave in inferior or lateral leads, with ST segment and T-wave changes, we think about myocardial infarct. Varying degrees of heart block we can see in patients with rheumatic or Lyme carditis. Atrial, junctional, or ventricular tachycardia and frequent atrial or ventricular ectopy, we think about the ventricular dysfunction. Assesses ventricular size and function and establishes whether the child has a structurally normal heart or underlying structural congenital heart disease. Important aspects are cardiac anatomy, arterial or venous connections, origin of coronary arteries, presence and amount of shunting, presence and amount of valvular stenosis and regurgitation, atrial and ventricular size, left ventricle and right ventricle global and regional systolic function, left ventricular diastolic function, estimation of right ventricular and pulmonary artery pressures. Also, an important aspect is pericardial effusion. Echocardiography helps us about pericardial. All of this, but for us, pericardial effusion is very important. Echocardiographic findings in children with heart failure vary depending on the mechanisms. When a child has ventricular dysfunction, we can see impaired ventricular systolic function, enlarged or dilated ventricle, left atrial and ventricular size may be helpful in determining chronicity. When we see volume overload, or when the child has volume overload, you can see atrial or ventricular enlargement, sizable septal defects with a large amount of shunting, severe valvular regurgitation. When child has pressure overload, we can see on echocardiography ventricular hypertrophy, severe outflow tract obstruction. For example, valvular, subvalvular, valvular or supravalvular aortic or pulmonic stenosis. Laboratory test BMP to assess, this is the first BMP to assess the severity of heart failure and monitor response to therapy. We use as a prognostic marker, and it helps us to differentiate cardiac disease from the non-cardiac causes of heart failure symptoms. Troponin, you know about troponin. This is a sensitive biomarker for myocyte injury. Complete blood count anemia. From complete blood count anemia may contribute to heart failure in a predisposed patient. Electrolytes, blood urea nitrogen, creatinine, liver function test, very useful. Hyponatremia may be seen in severe heart failure, renal impairment, contributing factor for heart failure, or exacerbates pre-existing failure. Baseline electrolytes are needed prior to initiating therapy with diuretics or angiotensin converting enzyme inhibitors to avoid potential side effects of these drugs. Very useful very useful will be elevated liver function test because elevated liver function test are in right side heart failure with hepatic congestions. We think about hepatic congestion. A useful evaluation, a useful test will be magnetic resonance imaging, cardiac catheterization, ambulatory electrocardiogram monitoring, exercise testings, and other studies, inflammatory markers, thyroid function test, metabolic screening, and genetic testing. Numerous non-cardiac conditions can present with signs and symptoms that mimic heart failure. The first positions is respiratory distress. The second position is failure to thrive. Gastrointestinal disorders, for example, protein milk allergy, cystic fibrosis, celiac disease, chronic infections, hyperthyroidism, and metabolic disorders result from this disease is a failure to thrive. Edema, when children are with renal failure, venous thrombosis, or adverse drug effects, there is edema, and this is reason for differential diagnosis with heart failure. Shock is the next differential diagnosis. The reason sepsis or hypovolemia, and the next steps is management of heart failure. Management depends on etiology and severity. Begins with an assessment of the underlying cause of heart failure. Pathophysiologic catheterization helps us guide the approach to the management. Goals for children with heart failures are to relieve symptoms, the first, very important. The second is decrease morbidity, including the risk of hospitalization. The next is slow the progression of heart failure, and the last is improve patient survival and the quality of life, the most important for sure. Corrective reversible conditions that may be causing or contributing to the heart failure symptoms. They are anemia, hypertension, renal failure, obesity, or malnutrition, respiratory disorders, thyroid disorders. The next step is ensuring adequate nutrition, very important in management of children with heart failure, promoting healthy and safe exercise. Approach to heart failure management. The first step for patients with structural heart defects is volume overload, pressure overload, and preserved ventricular function. And this lead to these are the mainstay of management. Mainstay of management in these patients is surgical or catheter-based interventions to correct the underlying defects. Medical therapy may be needed for stabilization or symptom relief while awaiting a more definitive intervention. For this disorder, the most important are surgical treatment. For patients with ventricular pump dysfunctions, the therapy is provided based on the stage of heart failure, stage A, for patients at risk for heart failure who have normal cardiac function and size. Lead to not treating in these patients, not treating with heart failure specific therapies. When the patients are in stage B, for asymptomatic patients with abnormal systemic ventricular function, therapy in this patient, therapy is with an angiotensin converting enzyme inhibitor. Intolerant of ACE inhibitors patients, we can use angiotensin 2 receptor blockers. When the patients are in stage C, this is for patients with current or past symptoms and structural or functional heart disease. Initial treatment with ACE inhibitor and an aldosterone antagonist plus oral diuretic therapy as needed for overload. Sorry. After a few weeks of stability, a beta blocker is added if there is no improvement in left ventricular dilation and dysfunction. When the patient, the children, are in stage D, these patients are with end-stage heart failure who are refractory to oral medical therapy. We can perform intravenous administration of inotropes and diuretics and non-pharmacologic interventions, positive pressure ventilation, cardiac resynchronization therapy, mechanical circulatory support, and the last step is heart transplantation. On pharmacologic therapy is renin, angiotensin, and aldosterone system inhibition. The first is heart failure leads to activation of the renin, angiotensin, aldosterone system and increased sympathetic tone. And ACE and AC and angiotensin receptor blockers inhibit the DC system, RAS, and the result is decreased afterload and promoting reversal of ventricular remodeling with long-term use. Angiotensin converting enzyme inhibitors, They are the first line component of therapy for children with stage B and C heart failure. The next group is for patients unable to tolerate ACE inhibitors due to cough or angioedema. You know from cardiologists that the adverse effect on ACE inhibitors are cough, mainly. The next group is the next group pharmacologic therapy is diuretics. They decrease preload by promoting natriuresis and provide relief of volume overload symptoms such as pulmonary and peripheral edema. Diuretics are used to treat children with stage C or D heart failure. Digoxin has positive inotropic effect, not recommended for children with asymptomatic ventricular dysfunction. Previously, dioxin was the mainstay of heart failure management, but until 1990s, but its role nowadays diminished. Beta blockers usually added to an established regimen of diuretics, digoxin, and ACE inhibitor. Discontinued in patients with decompensated heart failure. Pulmonary vasodilatator in children with right heart failure due to pulmonary hypertension. They are useful in this situation. Drug therapy for advanced heart failures are intravenous diuretics and inotropic agents. They are generally used in hospitalized patients with stage D heart failure. Inotropes are useful in the setting of low cardiac output. Their effect is mediated through higher intracellular cyclic monosulfate levels by increased production or decreased degradations. This is effects of inotropes. These are effects of inotropes. Therapeutic interventions for selected patients with advanced heart failure when they are refractory to pharmacologic therapy. They are in stage D, are positive pressure ventilation. The second is mechanical circulatory support in patients with end-stage heart failure. And the last step is heart transplantation. Long-term health maintenance in children with heart failure. The first question is are immunizations. The children should receive all routine childhood vaccinations. Very important is monitoring of growth parameters, monitoring for cardiac symptoms, poor weight gain, tachypnea, dyspnea, syncope. Very important is treatment of respiratory illnesses. Exercise, we have to know about exercise and sport participation because they are children and children want to exercise, want to be a sportist. Antibiotic prophylaxis is prevention of bacterial endocarditis. Important is planning of non-cardiac surgery. Children with heart failure are at increased risk for adverse events when undergoing surgery and other procedure under anesthesia. You can, and very important airplane travel, but these children can use airplane. Colleagues, this is the last slide for you in the from this lecture. And if you have any questions, ask me. Irregular. This is lecture very. I know that this is very difficult for you, but if you write in home, you can understand all of this slide, all of this tissue. Diabetes. You you don't have the lecture regarding diabetes now or the next time? For a while, please. I will check, and maybe now I will give the lecture. Are you writing? No. By email? I will try now. Please wait for a while. It's possible now. Any problem? Any problems? No, okay. Okay. Have a nice day, colleagues. Good luck in exams. And maybe we will see soon. Bye bye.